Hi everyone, and welcome to our module on neuromuscular blockers. So I think of anesthetics as falling into four general classes. The first two are the inhaled and the intravenous anesthetics, and these are usually used as general anesthetics to make a patient unconscious. The next group are the local anesthetics used to numb the skin or a nerve, and then finally we have neuromuscular blockers, which are used to create paralysis. So I've listed on this slide the agents that are used as paralytics. So the first one is succinylcholine, and it's really in a class by itself because it has a different mechanism from all the others, and we'll talk about that in a minute. The other drugs are turbocurarine, atracurium, mivacurium, pancuronium, vecuronium, and rocuronium. And so let's talk about why you would want to give a paralytic to a patient. I mean, you can put them to sleep with another anesthetic agent, so why do you need to also paralyze them? Well, there are some surgical procedures where they don't want the muscles of the abdomen to contract, so a paralytic can be useful there. Sometimes paralytics are given to patients in the intensive care unit because if they're severely hypoxic, paralyzing the muscles of the chest wall has been shown to improve oxygenation. And then finally, if it's an emergent situation and a patient is really struggling to breathe, you sometimes want to paralyze them and put them to sleep very quickly so you can put them on the ventilator, and that's called rapid sequence intubation, and we'll talk about that in a minute. So all these agents are used to make someone paralyzed in these special circumstances where you want them to not be able to contract their muscles at all. So succinylcholine is in a class by itself. It's different from all the other paralytics, and that's because it is a depolarizing neuromuscular blocker. All the other paralytic agents block depolarization of muscle cells. Succinylcholine actually causes depolarization of muscle tissue. It's basically two acetylcholine molecules stuck together, and it's a very strong nicotinic receptor agonist. So it will cause sustained depolarization of the muscle, and over time this will prevent muscle contraction so that you get paralysis. The way succinylcholine works is that it causes two phases of so-called depolarizing block. In phase 1, the muscle depolarizes and the muscle begins to fasciculate. In phase 2, the muscle's been so stimulated that it is now desensitized. Depolarization has occurred throughout the muscle tissue, and basically the muscle is no longer responsive to acetylcholine. And that's how a depolarizing block of muscle contraction works. So let's talk about the two phases of depolarization in a little more detail. Phase 1 is called the depolarizing phase. So succinylcholine is going to depolarize the muscle tissue, and sodium channels will open and then close, and they will become inactivated. At this point, the membrane potential needs to reset so the muscle can work again. Now, normally, acetylcholine gets hydrolyzed very quickly by acetylcholinesterase, and then the muscle cell can reset and contract again. However, succinylcholine is not metabolized by acetylcholinesterase, so the result is you get prolonged activation of acetylcholine receptor sites, and the muscle cannot contract, and this is called the depolarizing phase of succinylcholine block. Now, phase 2 is called the desensitizing phase. Normally, acetylcholine washes out quickly and there's no desensitization, but the longer depolarization by succinylcholine desensitizes the muscle tissue. So even after the succinylcholine moves out of the way in this phase and the receptor is available, the muscle is not going to contract. It's become desensitized, and this is phase 2 of succinylcholine block. So you want to keep this simple for yourself. Just remember that phase 1 is the depolarizing phase when succinylcholine is depolarizing the muscle. And in phase 2, succinylcholine has moved out of the way, but the muscle is desensitized. Succinylcholine is very fast acting. It has a quick onset of action and then a rapid washout. One very important thing to know is that there's no reversal of the effects of succinylcholine. So with the other neuromuscular blocking agents that we'll talk about in a minute, you can administer an acetylcholinesterase inhibitor to flood the synapse with acetylcholine and reverse the effects of the paralytic agent. That is not done with succinylcholine. The reason is because during that phase 1 depolarizing block, succinylcholine is bound to the receptor sites, and flooding the synapse with more acetylcholine will not help. Now, some textbooks will tell you that phase 2 is reversible, and while this is technically true, clinically no one reverses succinylcholine. The main reason is because the washout is so rapid that there's no reason to reverse it. The other reason is it's hard to tell the difference between phase 1 and phase 2 block when you're looking at the patient, so you don't know whether the reversal agent will work. The main side effect of succinylcholine is elevated potassium, and this is particularly dangerous in burn patients or dialysis patients or any patient who may have a high potassium at baseline. If you administer this drug and raise the potassium further, you can put the patient into cardiac arrest. And then the other dangerous side effect of succinylcholine is malignant hyperthermia. So let's talk about malignant hyperthermia. It's a rare, dangerous reaction that occurs after patients receive halothane, which is an inhaled anesthetic, or succinylcholine. These patients will wake up from surgery and they'll have a very high fever and muscle rigidity. And you should remember those two things because that's a classic presentation for a board question on malignant hyperthermia. They'll also be tachycardic and hypertensive. There will be extensive muscle damage. So potassium will spill out of their muscle, so will CK. The potassium can cause arrhythmias. The creatinine kinase can cause renal failure. And we think this happens because patients have a problem with something called the ryanodine receptor on the sarcoplasmic reticulum. This is a calcium channel in the sarcoplasmic reticulum of muscle tissue, and it's abnormal in patients who get malignant hyperthermia. We think it may be passed down in an autosomal dominant fashion. This receptor dumps calcium in response to these drugs, and the calcium leads to massive consumption of ATP as the sarcoplasmic reticulum tries to reuptake that calcium. All this ATP consumption leads to heat, and the heat is what causes the tissue damage, and that's why it's called hyperthermia, and it presents with a high fever. And you treat this with a drug called dantrolene, which is a muscle relaxant. Okay, so that's succinylcholine. Now let's talk about the other neuromuscular blocking agents, and these are called non-depolarizing because they don't depolarize the muscle the way succinylcholine does. And I've listed all of them right here for you. These are competitive antagonists that compete with acetylcholine for nicotinic receptors, and they produce paralysis by blocking acetylcholine from being able to do its job. Now you should know that many of these cause a marked histamine release, so patients can get hypotensive and can have a compensatory tachycardia. And you can reverse these drugs by flooding the synapse with acetylcholine, and the way you do that is by giving an acetylcholine esterase inhibitor, and that floods the synapse and bumps these drugs out of the way so the muscles can begin working again. Just for review, these are some of the acetylcholine esterase inhibitors that are sometimes given: physostigmine, neostigmine, pyridostigmine, and edrophonium. And we talk about these in the lecture on the autonomic nervous system. You should know about something called ICU weakness. So sometimes paralytics are given to patients on the ventilator in the ICU because it's been shown to improve oxygenation. So if you have a patient with a really bad pneumonia who's severely hypoxic, you can paralyze them, and it sometimes helps to get oxygen into their bloodstream. The problem is giving these paralytics is associated with prolonged weakness after they've been in the ICU. And ICU weakness is a big problem if you ever meet a patient who is in the intensive care unit for several weeks on a ventilator. They may recover from their acute illness but never recover all the function they had before they got ill. And so people try to avoid paralytics because of this association. The other thing I want to tell you about is how you assess neuromuscular blockade. So if you have a patient who's put to sleep and you administer a neuromuscular blocking agent, how do you know if you've given them enough? And the way you do this is by testing them with something called a peripheral nerve stimulator. You give 4 impulses to a nerve and you see how much they react. So this is called the train of 4, and I've shown you a picture of it right here. You put these little stimulators on the patient's wrist, and then it sends a little electrical jolt and it makes the fingers contract. And this is how you assess neuromuscular blockade in patients under anesthesia. Your goal is to usually see them contract 1 time out of 4 stimulations or 2 times out of 4 stimulations. If their fingers never contracted in response to the electricity, that would mean that they are overblocked. And if they responded 4 times, that would mean they're not blocked enough. Okay, the last thing I want to tell you about is something called rapid sequence intubation. So if you're ever in the hospital and they call a code blue for a patient in respiratory distress, an anesthesiologist will come and do something called rapid sequence intubation. And what they want to do is make the patient sedated and flaccid as quickly as possible so that they can put a breathing tube in. And the classic way you do this is to first give an agent that induces anesthesia, and that is usually etomidate. Sometimes it's ketamine or benzodiazepines, but it's usually etomidate. And then you give an agent that causes paralysis, and this is the one place where they often use succinylcholine. People don't like to use succinylcholine because of the hyperkalemia and the malignant hyperthermia, and you can't reverse it, but it's very useful here because it has the most rapid onset and rapid offset. So this will quickly paralyze the patient, and then along with etomidate, the patient will be unconscious, and they can put the breathing tube in and get them on the ventilator, and then the effects of these 2 drugs will rapidly wear off, and then another sedative like propofol or fentanyl can be given as a drip in the ICU to keep them sedated while they're on a ventilator. It's very uncomfortable to have a breathing tube down your throat, so patients on a ventilator need to be on some kind of sedative as long as you're going to keep them on the breathing machine. And that concludes our module on neuromuscular blocking agents.